Okay, so this is part two of the elimination lecture, and we're going to start with incontinence. And incontinence is the involuntary loss of urine control, and it can be caused by physical events, for example, immobility, fractures, restraints, weakness, or it can be caused by psychological causes, for example, dementia or confusion. And remember, you can be incontinent for stool and bladder. And in this situation, we're just talking about incontinence of urinary control. Now, I would like for you to be familiar with the different types of incontinence. The first one that I'll mention here is stress incontinence, and that's where a person is exercising or exerting themselves somehow physically, and they lose control of their urine. The second one is overflow incontinence, and this is where when the bladder gets too full or overdistended, they lose control and they will wet themselves. And the third one on the screen is called urge incontinence. And you and I know that when you have to go to the restroom, you have that urge that you need to go. Well, a person that has urge incontinence, when they have that feeling, whoop, it's too late and it's gone. So they wet themselves when that urge first hits. Okay, and the last two types of incontinence that I'm going to talk about here. The first one is detrusor instability, and this one you guys will learn about when you get the third and fourth semester. And it has to do with spinal cord injuries. And the person loses control of the detrusor muscles and the nerves, and so they can't control their bladder and they become incontinent. But that one you'll learn about in a few semesters. And then the last one, and probably the most common one that you're going to see, is functional incontinence. And this is where they lose control of urine due to environmental, cognitive, mobility issues, and dexterity deficiencies. And a great example of this would be if you were to go down to a skilled nursing facility and you take a person that is normally active, stick them in a room, stick them in a bed, put the side rails up, and if you don't offer them a bedpan or the opportunity to go to the restroom, well, when their bladder fills up, then they lose control and they develop what we call functional incontinence. Or this same person, let's say they develop dementia, and so their body tells them we need to go, but their mind isn't working properly, and so they wet themselves also. So these are all examples of functional incontinence. And one last example would be, let's say you have an older person that falls and breaks an arm or breaks a leg, and so now they're in a bed and they can't get up to go to the restroom, and we don't offer them an opportunity to use the restroom, and so they're also an example of functional incontinence. Okay, so those are examples. This next slide here, we talk about the treatment and the different interventions that I'm going to talk about. The first one is more of a preventative type intervention, and this is where you encourage the person to either use absorbent pads or wear, diapers or undergarments or depends, just to give them a little backup safety, in case they wet themselves and they're out in public. So these are interventions that just help prevent embarrassment and stuff like that. The next one is Kegel exercises, and this is where we want to teach them to strengthen those muscles on the pelvic floor so that they have a greater sphincter tone and they can go longer before they have to use the restroom. And the next one is bladder training. Bladder training, it's very common. We used to use it a lot on patients that had Foley catheters for a long period of time, and their sphincter would get kind of lazy. And so what we do in bladder training is we teach the person to gradually lengthen the time between voiding so that they will be able to go a longer period of time, but they can go out and run errands and stuff. So I'll explain how this works. So let's say we have a patient that maybe they wet themselves every 30 minutes or so, or that's when they go to the restroom. Well, what we do is we'll say, okay, let's have you go 40 minutes today. And then the next day you say, okay, let's have you go 45 minutes. The next day, let's have you go an hour. And we gradually increase the length of time. And we try to build it up to something like 3-4 hours. And that way the person, while they're out in the community, they know that I can last 3 hours, so they can go to Target or go to the bank or run to get gas or something. And if it's been like 2.5 hours, then they know they need to go and find a restroom. So it's a way of giving them a little bit more control. There's also different medications that we can give them. The anticholinergics are very common that help increase sphincter tone. There's obstructive devices, and I won't go too in detail on these. If you look in the book, there's pictures. Um, Obstructive devices are things that help the person to gain sphincter control. So, for example, a guy could the doctor could prescribe something like a penile clamp, and it's like a little clamp that fits on the penis, and they tighten it up, and then they can go around, and then when they have to go to the restroom, they can go to the restroom, loosen the clamp, and then they can go. And for females, there are often devices that they're going to put up into their vagina that puts pressure up on the urethra, and then when they need to go to the restroom, they can pull that device out and then urinate. And so I'll let you look at those on your own. And then surgical procedures, usually they don't do that for most adults with incontinence. Surgical procedures are usually saved for children that have congenital anomalies. Okay, acute gastroenteritis. And this is something you'll see again next semester in pediatrics. This is where the person has either a viral or bacterial infection, and it leads to horrible diarrhea and vomiting. And it's very common. You've probably heard stories of people being on cruise ships, and someone may have norovirus or rotavirus, and it spreads from one person to the other, and the next thing you know, there's a whole bunch of people on board the ship that have horrible diarrhea and nausea and vomiting. But the pathophysiology is that a bacteria or virus gets into the GI tract. It leads to an inflammatory reaction, and whenever you have an inflammatory reaction, then fluid's going to dump into the area. And when you have fluid dumping into the GI tract, then you're going to have increased peristaltic waves and diarrhea. So the signs and symptoms would be nausea, vomiting, diarrhea, fever, abdominal cramps, aches and pain. The treatment, you want to give them fluids because often they will be dehydrated. If they have nausea and vomiting, we'll give them antiemetics. Now, this is a little controversial because often, initially, the doctor will want them to evacuate the bowel to get rid of the causative organism. But then once that is gone, then they may give them antiemetics to stop the nausea and vomiting or antidiarrheals to stop the diarrhea. And then if it's caused by a bacteria, they'll also give them antibiotics after they get a culture and sensitivity. And we always want to teach our patients good hand washing, cleanliness, because that's how often these are spread. It's through the oral fecal route of transmission. So you want to teach people to wash their hands and clean the environment well. Don't share towels and stuff like that, and that'll help stop the transmission. And often if it's a infection like Shigella or Salmonella, they'll have to have 3 negative stools before they'll be released from the hospital. Okay, the next one is Clostridium difficile, or a lot of times people call this C. diff. And C. diff is a disorder where a lot of people have C. diff inside their GI tracts, but it's kept in check by normal flora. And if someone's on long-term antibiotics, what happens is it wipes out the normal flora, and then the C. diff proliferates, and it leads to a smelly, watery diarrhea. And if you've smelled it, it smells really poorly. But it's a watery diarrhea, and it can't be treated with, the normal anti-diarrhea agents that we have, like Imodium AD and stuff like that. Those don't work. It has to be treated with Flagyl, vancomycin, and one thing to note here is that the spores can survive in the environment for up to 70 days, and so all the equipment has to be disinfected before it comes out of the room. You want to teach really good hand washing here, and this is where we want to teach people to use soap and water, not the alcohol-based hand wash, because that is ineffective against Clostridium.